Hi everyone, this is Tim, your Block 3 lecture instructor, and today's voiceover PowerPoint is going to be on two other endocrine disorders, specifically diabetes insipidus and SIADH. These are two other endocrine disorders that are not very exciting. They're not very common in the med-surg setting at the bedside, but they are both still important. And I have actually taken care of somebody who has had um, diabetes insipidus before, I believe. The story will probably come to me as I tell, do the PowerPoint. So anyways, it's also very short. There's about maybe 15 slides, very specific, very detailed, but I try to make it as comprehensive and easy as possible. So, diabetes insipidus, what is it? The volume and composition of your body fluids remain balanced through a combination of oral intake and excretion by the kidneys. So, just like I told you and all the other PowerPoints, what goes in must come out, right? The rate of fluid intake is largely governed by thirst, although your habits can increase your intake far above the amount necessary. So you're thirsty, you drink water. You drink plenty of water to keep yourself hydrated. Anything more than that, you're going to pee it out. That's basically ins and outs, right? Now, if you happen to go outside and it's 110 degrees outside and you're sweating up a storm, obviously you're going to need to drink more fluids, and you may have to drink a couple bottles as opposed to just one bottle an hour just to make sure that you're hydrated. So the rate of fluid excreted by your kidneys is greatly influenced by the production of antidiuretic hormone, which is also ADH. It's also known as vasopressin. Your body makes ADH in the hypothalamus and stores the hormone in your pituitary gland. ADH is released into your bloodstream when your body starts to become dehydrated. So if you, aren't drinking enough and you're outside, it's 110 degrees, you're perspiring, your body will actually start to, or your hypothalamus will actually release the ADH in order to constrict your blood vessels so that way the blood still circulates the way it should and to keep your blood pressure balanced. ADH then concentrates the urine by triggering the kidney tubules to release water back into your bloodstream. So in order for you to become more hydrated within your circulatory or vascular system, your kidneys will actually pull the water out of the interstitial space and put it back into your vascular system so that way your blood pressure is maintained. So, types of diabetes insipidus. There's central diabetes insipidus. The cause is usually in adults, and it's a damage to the pituitary gland or the hypothalamus. This damage disrupts the normal production, storage, and release of ADH. The damage is commonly due to surgery, a tumor, or illness such as meningitis, inflammation, or head injury. So I work for a trauma center, and I have worked on the trauma floor, and we also have a neuro floor, and I've taken care of patients who have had head injuries, whether it's them falling and hitting their head or being ejected from cars through accidents, driven through windshields, what have you. And this is where I probably have seen them the most, and it's not necessarily specifically diabetes insipidus, but because of the damage to their brain, which then for either a short period of time or a long period of time causes the hypothalamus and the pituitary not to work correctly. So I've seen probably more of this than anything else. There's nephrogenic diabetes insipidus. This occurs when there's a defect in the kidney tubules, the structures of your kidneys that cause water to be excreted or reabsorbed. This defect makes your kidneys unable to properly respond to ADH. The defect can be due to an inherited or genetic disorder or a chronic kidney disorder. So again, your tubules are meant to pull and push water in and out, and if they're not working correctly, then the ADH is not necessarily able to do what it's supposed to do. There's also primary polydipsia. This condition, also known as dipsogenic diabetes insipidus or psychogenic polydipsia, can cause excretion of large volumes of dilute urine. Rather than a problem with ADH production or damage, the underlying cause is intake of excessive fluids. Prolonged excessive water intake by itself can damage the kidneys and suppress ADH, making your body unable to concentrate urine. So essentially, this is for people who have some sort of psychological problem where they feel the need to drink gallons and gallons and gallons of water, and that's what's actually doing the damage, not only to their kidneys, but it's also not allowing the ADH to do its job. So for an assessment, your patient is going to have a lot of polyuria, 4 to 24 liters a day. They're going to have polydipsia, which makes sense. They're going to have low urine specific gravity, and that's because of the fact that they're flushing it all out. And they're also going to have fatigue, muscle pain, and weakness, probably more from the lack of or low potassium and sodium. They're also going to have a headache, and their vitals are going to be a low blood pressure and an increased heart rate because of the fact that they're dehydrated and their heart is trying to compensate for that. So for symptoms, if it's due to dehydration, they're going to have dry mouth, changes in skin elasticity, they're going to have low blood pressure or hypotension, elevated blood sodium, which is hypernatremia. They're going to have fever, headache, rapid heart rate, and weight loss. If it's an electrolyte imbalance, they're going to have fatigue and lethargy, nausea, loss of appetite, muscle cramps, and confusion. So for interventions, you're going to monitor vital signs, making sure that their blood pressure and heart rate are within normal limits. You're also going to do neuro and cardiac checks, whether it be neuro check and for confusion and lethargy and some sort of change in neuro status. You also could do cardiac, whether it be EKGs, whether it be echoes, whether it be symbols on the vitals, listen to their heart, but you're going to check that also. You're also going to look at labs for electrolytes. You're definitely going to monitor ins and outs, making sure that what goes in is actually coming out. You're going to monitor their weight. If their weight decreases, they're losing too much fluid, and if their weight increases, then they're retaining it. You're also going to look at their urine-specific gravity. You're going to maintain safe environment for patient due to postural hypertension. So again, this is a patient who's going to be losing a lot of fluid, and with the blood pressure, it just takes them to stand up way too fast and fall down. So for diagnostics, they're going to do a water deprivation test. This test confirms the diagnosis and helps determine the cause of diabetes insipidus. Under medical supervision, you'll be asked to stop drinking fluids for a time so that your doctor can measure changes in your body weight, urine output, and concentration of urine and blood when fluids are withheld. So your doctor may also measure blood levels of ADH or administer synthetic ADH during this test. They'll also do a urinalysis. This is the physical and chemical examination of the urine. If urine is less concentrated, meaning the amount of water is high relative to other excreted substances, it could be due to diabetes insipidus. Or they may actually do an MRI. An MRI of the head is a non-invasive procedure that uses a powerful magnetic field of radio waves to construct detailed pictures of the brain tissues. Your doctor may want to perform an MRI to look for abnormalities in or near the pituitary gland. So for treatment, for central diabetes insipidus, because the cause of this form of diabetes is lack of ADH, treatment is usually with a synthetic hormone called desmopressin. You can take desmopressin as a nasal spray or oral tablets or by injection. The synthetic hormone will eliminate the increase of urination. For most people with this form of condition, desmopressin is safe and effective. If the condition is caused by an abnormality in the pituitary gland or hypothalamus, such as a tumor, the doctor will first treat the abnormality. Desmopressin should be considered a medication that you take as needed. This is because in most people, the deficiency of ADH is not complete and the amount made by the body can vary day to day. Taking more desmopressin than needed can result in too much water retention and low sodium levels in the blood. Symptoms of low sodium include lethargy, headache, nausea, and in severe cases, seizures. In mild cases of central diabetes insipidus, you may need only to increase your water intake. So for treatment of nephrogenic diabetes insipidus, this condition is the result of your kidneys not properly responding to ADH. So desmopressin is not a treatment option. Instead, your doctor may prescribe a low-salt diet to help reduce the amount of urine in your kidneys The doctor may prescribe a low-salt diet to help reduce the amount of your urine the kidneys make. You also need to drink enough water to avoid dehydration. The drug hydrochlorothiazide, used alone or with other medications may improve symptoms. Although hydrochlorothiazide is a diuretic, usually used to increase urine output, in some cases it can reduce urine output for people with nephrogenic diabetes insipidus. And symptoms from nephrogenic diabetes insipidus are due to medications you're taking. So stop taking these medications may help. However, don't stop taking any medication without first asking your doctor. So treatment for primary polydipsia, because this is a psychological problem, there's no specific treatment for this form of diabetes other than decreasing the amount of fluid intake. However, if the condition is caused by mental illness, treating the mental illness may relieve the symptoms. Syndrome of inappropriate antidiuretic hormone, also known as SIDH, is the excessive ADH is released, but not because of the body's need for it. The cause may include trauma, stroke, or malignancies. SIADH results in water intoxication and hyponatremia. Symptoms include nausea and vomiting, headache, problems with balance that may result in falls, mental changes such as confusion, memory problems, and strange behavior. They also may include seizures or coma in severe cases. So for your assessment of SIADH, signs of fluid volume overload, changes in level of consciousness and mental status changes, weight gain, hypertension, tachycardia, anorexia, nausea and vomiting, and hyponatremia. Interventions are going to be monitor vital signs, cardiac and neuro checks, eyes and nose, daily weights, fluid and electrolyte imbalances, specific gravity, restrict fluid intake, administer diuretics, and medications that inhibit ADH-induced water reabsorption. Diagnostics are going to include comprehensive metabolic panel, a CMP, osmolality blood test, urine osmolality, urine sodium, and possibly an MRI in order to take detailed pictures of the brain tissues. They won't want to do this in order to find out if there's abnormalities with the pituitary gland. And that's actually pretty fast, 12 minutes. So in a nutshell, that's the two other disease processes within the endocrine system. I kind of ran through them because of the fact that they are pretty simple. Again, either your body is producing too much and it causes these symptoms and you will do these interventions, or it will cause too little. These are the symptoms and you're going to do these interventions. So if you have any questions, let me know and we'll discuss all of this in class.